Hi, all. Thank you for joining us for our March meeting of our remote monitoring working group. We have a special presentation today with some of our partners at UMMC to talk a little bit about research and their findings, and then just a quick recap of some of our funding efforts for further RPM research and an upcoming event later this week. So I'd like to introduce our guest speakers for today. We are grateful to be joined by Carly Brown, who is a clinical pharmacist at University of Mississippi Medical Center, as well as Kyle Brewer, who is a telehealth administrator also with UMMC. They'll talk a little bit about some of their ongoing research surrounding RPM, as well as some of their findings and insights. Thank you so much for joining, and I will turn it over to you all.
Okay. Thank you, Lydia, for that introduction. Just to be sure the slide's showing correctly.
Yep.
Okay, awesome. Thank you so much. So again, good afternoon and thanks for having us. We're excited to speak a little bit today about what we're doing here at the University of Mississippi Medical Center, Center for Telehealth and Emerging Technologies in our remote patient monitoring program. So we'll just take a few minutes to give a quick overview of some of our different RPM models, share some of our outcomes, and then a few lessons that we've learned as well along the way. So before we begin this work, especially our research work, is supported through our HRSA Telehealth Center of Excellence grant. So again, our objectives for the day will briefly cover how our RPM infrastructure has evolved. We'll walk through some different care models, highlight our outcomes, and then touch on workforce and sustainability. As many of you know, probably even if you're not very familiar with Mississippi, you probably do know that we face significant challenges, especially in regards to healthcare. We have a high chronic disease burden, a very rural population with limited access to care. And so the University of Mississippi Medical Center, or UMMC, really serves as a centralized hub in our state. And so telehealth and RPM specifically really became a key strategy to extend care beyond those traditional in-clinic care settings. Our RPM program did launch around 2014 and initially focused on diabetes only, which of course has significantly expanded over time. And a major turning point was when we started to integrate pharmacists into our care model, which really changed how we approached chronic disease management as a whole. So at a high level, our infrastructure includes, of course, remote monitoring devices that are integrated into the electronic healthcare record with daily nurse monitoring and protocol-driven alerts. But I think one thing that really sets our programs apart is how we act on the data. So not just how we receive the data, but what do we do with it once we do receive it? And so before we talk about our outcomes, I do want to make a little distinction about our RPM programs and our models. And we've essentially operationalized RPM into two different care models. We have our pharmacist-integrated optimization model and then our nurse-driven escalation model. So with our first model, we focus on chronic conditions such as diabetes, hypertension, chronic obstructive pulmonary disease, or COPD, and this includes a medication titration protocol. So the pharmacy team is actively titrating medication based on a collaborative practice agreement that we work under with collaborating specialty physicians. So we have cardiology, endocrinology, and pulmonary oversight with these programs. Whereas our nurse-driven escalation model is used more for maybe a little bit more complex conditions, so congestive heart failure, end-stage renal disease, maternal health, where we have nurses monitoring those biometrics still in both programs, but the nurses are escalating to the physicians as needed. And so the choice really depends on how intervention heavy and maybe complex the condition is that we're monitoring as far as which model we may choose to use. So just to hit a few high points on the workflows, of course, enrollment, kit delivery, patient onboarding, those are both essentially the same in both programs. But to point out a couple of steps in there where they differ, in the pharmacist integrated model workflow, we do have the pharmacy team where they're actually calling the patient at the very beginning to complete a full medication reconciliation. and address any barriers to adherence that the patients might face as early as possible and help them, to overcome some of those barriers to make sure they're getting the medications that they need. From there, we do titrate their medications based on the biometrics that we receive. So again, thinking about programs such as our hypertension and diabetes programs with this workflow. We still call the patients on a routine basis, but whereas if they're meeting their goals, their nurse may call them to continue to provide education, encouragement. But if they're not meeting their goals, then somebody on the pharmacy team will give them a call to actively titrate their medications. So the key difference here really is just that we're not just monitoring the biometrics that we receive, but we're really actively adjusting those medications in real time. And so that allows us to intervene much earlier and more frequently than we would if we were just using a traditional care model. And again, with the nurse-driven escalation, in contrast, it is more focused on monitoring and escalation. So it's a highly protocol-driven, and it works well for conditions where those medication changes may be less frequent or where there is a requirement for a specialist involvement. So those are just a few high points to note out on the differences in the workflows. Just one quick example. So if a patient has a repeated critical blood pressure measurement, then the nurse would then initiate the outreach, check on the patient, and if needed, escalate to the pharmacist for medication adjustment. Whereas in the nurse-driven models, the nurse would escalate to the provider in clinic. So that's kind of the what sets it apart there. So the structured escalation pathway is really kind of what makes this model work for us. So moving on to some of the clinical outcomes, we have certainly seen some strong outcomes across our programs. So just to point out a few for our hypertension and diabetes outcomes. So again, this is going to be more of that pharmacist-integrated approach. In hypertension, we looked back, we did an initial study with the hypertension program testing the model of having the pharmacist incorporated in the care team and in the workflow. And we kind of took a look back post-implementation to look at the long-term outcomes. So not just this, very controlled study setting, but how did that translate into the real world and directly implement it into the clinic workflow? And we found very similar results as we did with our pilot study. So significant reductions in both systolic and diastolic reduction, and particularly more reduction than those receiving in a matched cohort, those receiving in-clinic care only. So it has proved to be very successful in lowering blood pressure for patients with uncontrolled hypertension. Our diabetes program is also showing some very promising results. We're currently really analyzing that data, but some preliminary data is suggesting an A1C reduction of around 2% for our patients enrolled in the RPM program and receiving the medication management. Our COPD outcomes have also shown promising results, though we have a very kind of small cohort of patients. We only had 30 patients that we were able to kind of look at internally as a quality initiative or a quality improvement initiative project. And what we were focused on was the reduction in acute care utilization for COPD exacerbations. And we have, again, shown great results with this. So when we compared the year prior to RPM enrollment for patients with COPD and compared that time to when they were enrolled in the RPM program or receiving active management, we saw about a 68% reduction in hospitalizations and ED visits for COPD exacerbations compared to that 1 year prior to enrollment. And again, with congestive heart failure or CHF, again, this is a nurse-led monitoring program. And of about 100 patients that we followed in that program, we saw nearly a 50% fewer hospital days per year when compared to the year prior to their RPM enrollment. So very good outcomes on utilization as well. So one thing that I do want to touch on too that I think has been critical for scaling our programs is the good thing about UMC is it is a teaching hospital, and so we do have access to learners, specifically pharmacy learners. And so we have created a structured telehealth preceptor model where we actively integrate pharmacy learners, and by pharmacy learners, I mean both pharmacy students and pharmacy residents, into our remote patient monitoring program. And over the past relatively 4 years, they have contributed thousands of hours to our RPM model. And that not only expands the capacity for us, but it also provides them with a very unique experience they may not, get information on while they're in school and other training. So a few key takeaways, I guess, from us is we've been working on our workflows and pushing out a lot of these outcomes. Some of the biggest takeaways for us would be that surveillance alone has limited impact. Medication optimization is certainly key. Clear workflows will enable sustainability. And then lastly, the workforce integration can certainly expand capacity as well. So I will next hand it over to Kyle just to briefly touch on how we're thinking about sustainability and some of our future directions.
All right. Thanks, Carly. So as we saw with Carly's information, there are different teams doing different things based on the needs of the patient. And so I think we're going to see a theme here as we talk through some of the sustainability aspects as well. So we've tried to set up the right team that is needed for each patient to really that leads to more improved outcomes. And so this aligns with CMS, where CMS is pushing the industry away from the traditional fee-for-service model that really encourages more volume, and more to the value-based model that encourages better outcomes. So as we're going along that path there, we're going to take a look at, we're going to highlight some of the differences between those two services. And then we're going to focus a little bit on the APMC and access models that are a little bit getting more onto the value-based side of that spectrum there, and what we can do as different teams to prepare for those. So next. All right, so two key differentiators in these models is the payment structure and the outcomes that have to be reported. So the RPM and CCM, for those, you're going to be reimbursed for a specific task and the amount of time spent with patients. So that's the more traditional models that we're all used to. And as we get into the APMC, so that's going to be more of a bundled per patient per month model, and that's going to be based on how many chronic conditions the patient has. And then as we move into the access model, we're looking at more outcome aligned payments, the OAPs, and that's going to be on the different types. So what's the type of condition that they have, and then everyone's going to be required to report the values for their patients and their patient population. And CMS is going to expect improvements, and the payments are going to be aligned with the clinical improvements of those patients. And so it's up to each organization to deliver effective services to improve that care, and it's going to incentivize controlling the costs. And so you're going to be incentivized for organizations to really look at how you're providing care, making sure it's effective, and yet making sure that you're controlling your costs to deliver that care. All right, so next. And so diving into those two models, really, they're going to encourage more proactive care to patients, and you're going to look at casting a larger net out there to identify patients. So you're not traditionally, a lot of people will just look at high-risk patients, and they're taking a reactive approach to providing that care management. So we're kind of flipping the script a little bit, and we're looking at more proactive, but we're also looking at probably a lower level of engagement than we're used to as well over a broader population. So that's going to require a shift. That's going to require different teams, different dynamics, and a different workflow to handle those types of models. And so in order to adapt to that shift, I think one of the important things there is a robust risk stratification for patients. If a patient is high risk, uncontrolled patients on the program, they're going to have different needs than, say, an engaged pre-diabetic patient who's really proactive in trying to improve their health. And so for lower risk patients, you want to look at automating as much of the enrollment process and some of the education features. You want to get your nurses, we want to look at getting nurses doing nursing stuff, getting our pharmacists to do their pharmacist work. Let's get some of the admin stuff out of there and let's get that automated as much as possible. That way that our team, our clinical teams can actually see more patients and deliver the care that they need to be carried, they need to be doing. So um, in order to do that, we're going to have to rely on technology more. We're going to have better software that really is more engaging and provides better information to our clinicians about when and where to engage with the patients. And that just leads to possibly the use of AI to help to identify and support our clinical teams better so that they can see the patients better. And so that's a broad overview of how teams are built differently based on different types of patients. And so I think at the end of the day, this change will help deliver more effective care, but also helping to control the costs and in order to get that right care to the right patient at the right time. So that's the goal of this model that CMS is pushing, and that's something I think that we've all got to look at as far as how our teams are built and our workflows are engaging our patients. Right, next, Carly, I'll hand it back to you. Do you want to wrap up with what's next?
Yes, I will. So just kind of building upon what Kyle said, I think he led us directly into this. But we're always certainly looking for areas of improvement and areas of growth. And I think one big piece on that is showing our value behind what we can change with remote patient monitoring and in chronic disease management. And so not only, expanding our disease programs, but also, shifting to this whole person care and shifting to where we're improving the population as a whole and not just looking at, individual maybe chronic conditions in silos. And so I think that's a big area that we, plan to continue to not only do research in, but to make a positive impact in as well. And I will close there and turn it over back to you, Lydia.
Great. Thank you so much for sharing some of your research and program insights as well. I'm wondering if there have been any policy or reimbursement changes over the past year or so that you've seen that have either benefited or changed the way you implement your remote monitoring programs?
So I'll take some of that as we see CMS coming out with different models, that is, like I said, really pushing us to look at how efficient we really are. And as we look at scaling to more patients, can our nurse do the same function that they're doing for a couple hundred patients, for 500 patients, for 800 patients, for 1,000 patients? And what's realistic? What's clinically realistic for them to do? And we've got to maintain quality. And so seeing where that reimbursement or what really kind of gives you an image of what they're wanting whenever you start seeing some of these reimbursement models. And you have to kind of look at that and say, okay, well, what's going to be required for us effectively to deliver care and still get paid for that? And honestly, we talked with a lot of other people too, and a lot of other people are kind of trying to figure it out at the same time. And so as more people become interested, we're trying to better prepare ourselves for that. So I think right now it's still, for us, it's still in the phase where we're planning for more volume in those types of areas. And so it hasn't been a drastic change yet, but it's led to a lot of conversations and a lot of planning on our part.
Yeah, and you had mentioned the access model, and there was a lot of buzz a few weeks ago when CMS released its reimbursement rates, and that they were pretty lower than was expected. Has that changed how you're approaching participation in the model, or do you see any recalibration since those payment rates have been released?
Yeah, I think it put a bucket of water on everybody's expectations there. But they're also not going to give the service away for free, and you have to also control to make sure there's not a lot of fraud there either. Um, I think for us, the challenge more was who's the right person that they are targeting to provide that type of care. So we're in a situation where we provide services within our own academic medical center, and then we also help support people outside of the medical center as well. And so, there were some. It really wasn't about the payments for us. It was more about some of the restrictions around, who could provide and who you could not have two people under the same tax ID providing the service and getting that reimbursement. So if, for example, if we were to provide access type care for our family medicine department, then our family medicine department would not get E&M level reimbursements. So that was a restriction there. So that really put a big hindrance on us to be able to do that, to participate in that program. Um, and so then you really just, it's kind of a who's the right fit. That was really kind of a lot of our conversations. And so just to kind of, I don't know that we've actually got it figured out perfectly yet, but I think you start seeing people who are independent of health systems that have the technology and have the clinical teams available to provide it to different people in need, other healthcare organizations. So I don't see it. I think some of the restrictions plus the payments aren't exactly where people were hoping it was going to be. I think that kind of put it in a position where it'll probably fit for some people, but not as widespread as I think everybody was hoping it would be.
For sure, that makes sense. And I think over the course of the pilot project and some of the demonstration, we'll probably get a better picture of where it's working and where it's not.
Yep.
Great. Well, thank you both so much for joining us to talk a little bit about some of your research. We really appreciate all the work that you're doing. And I hope that you all have a great rest of your day. Thank you so much for joining.
Thank y'all.
Thank you.